Good morning to all respected seniors and my dear colleagues. First of all, I would like to thank the whole team of INCARS for giving us a chance to present our share of experience at this precious podium. Uh, Today I'm here with a case who was post-Bentals, post-CABG, had 100% occlusion in left main coronary artery and a partially stuck valve. The background is he was a 63 years old hypertensive male who landed in our emergency with excruciating angina. His blood pressure was falling with a systolic blood pressure of 70 millimeters of mercury. His ECG revealed a true posterior wall MI with AV dissociation, and the findings were confirmed by regional wall motion abnormality in LCX territory with a moderate MR, which was likely acute. His history revealed that he had a bicuspid aortic valve and a post-stenotic dilatation for which a Bentals procedure had been done, which is a composite graft of aortic valve, aortic root, and the ascending aorta, which has been done about 12 years back, and Lima had been placed in distal LAD with non-obstructive LCX and RCA disease. Unfortunately, he had stopped the anticoagulants few months back. As he was tossing around, restless and breathless, we were thinking how to go ahead because this was for the first time in our interventional journey that we came across such a case. And what would be our route? Will it be easy to hook the neo-ostia or the coronaries? There was no much data or literature which we could search at that point of time in a short span of time. We discussed the case with the family, and family decided to go ahead with the treatment. And we made our mind how to go ahead. This is the ECG on presentation. So we formulated our strategy. We took our default right radial route, and we knew that there may be challenges entering into the aortic root and hooking the neo-ostia. We decided against assessing Lima at that time because there was no regional wall motion abnormality in LAD territory, and criticality needed quick and judicious solutions. CAG was done with a 5 French system through a 6 French sheath up front. And let's see what we got. This is angiogram done with a Tiger, 5 French Tiger. And you can see there's a total occlusion of left main coronary artery. And there's some sluggishness of the movement of the valve leaflets as well. RCA was more or less normal. So we decided to go ahead and try to open the blockage, and we cannulated the neo-ostia with extra backup and started doing our PCI. We took our default, workhorse wire, which is BMW 014, and since LCX was the culprit artery, we tried to open the artery first, though we could negotiate it only with the help of a balloon support. And as soon as the wire crossed into the vessel, you can see the flow restored, and there is a very big chunk of thrombus in the distal left main. We started dilating the lesions, and we wanted to upsize the balloon at this time. You can see and do some thrombosuction. You can see there's a big thrombus again at distal left main, and flow stopped again in septal stopped flowing, and D1 stops flowing again. And at this time, when we were trying to do thrombosuction and put in some balloons, nothing was going. So we took a buddy wire and for extra support, and after that started dilating the lesion again and did multiple runs of thrombosuction. And took the buddy wire out, gave some intracoronary injections of adenosine, NTG, nicorandil, and a bolus of tirofiban. And still you can see the thrombus, but we didn't give up, and we gave multiple runs of thrombosuction, and finally the thrombosuction succeeded, and this is what we got, a TIMI3 flow in both the vessels. Septal started flowing again, and D1 and L6 also. And at this moment, we did not stent the lesion, thinking that it's a very high thrombus burden, high thrombotic milieu is there. And we got a TIMI3 flow, patient symptoms improved, and he was hemodynamically stable. And we left the lab with a TIMI3 flow without adding another implant in such a scenario. And God had been kind. So this is ECG 2 hours after procedure. He came back to one-to-one conduction, though with PR prolongation, which later on settled. And aortic valve was observed again after 48 hours. Now you can see brisk and crisp movement of the valve leaflets. So the take-home message is encountering coronary occlusions 10 years post-valve replacement and Bentall's procedure are uncommon. Taking good history and on anticoagulation status can guide treatment strategies in such cases. Hooking the neo-ostia from radial route is challenging but can be done very carefully. Thrombosuction should be mandatorily performed in high thrombotic burden situations to avoid another implant insertion as in this case. And after PCI, the mechanical valve should be observed positively and closely for its movement. Thank you so much for your patience here.
Nice case, Neelam. Two questions. Number one, what was the gradient across the aortic valve? Did you find any gradient across the aortic valve?
No, ma'am, we didn't check it during primary PCI.
So you think there was a stuck valve or there was no stuck
Ma'am,
valve?
on echo there was no stuck valve, but because of the sluggish movement of probably it was a stuck valve.
Yeah.
Maybe the thrombus had formed on the valve and then dislodged and embolized into the main coronary left main.
So your clinical diagnosis was ACS and not a stuck valve?
No, it was clinically it was not a stuck valve. When we found the sluggishness of the valve movement on angiogram, then only we thought that would be.
What was the management about the thrombolytic therapy in such case? Aggressive antithrombotic. What was the INR status?
Ma'am, he had stopped
stopped,
anticoagulants when he came. His INR was just 1.2. And then we put him on dual antiplatelet and acetrom again. And we continued all 3 drugs for 1 month. And later on, we shifted him to aspirin and acetrom. Now he comes for regular follow-up and his INR stays around between 2.5 to 3.
So I fully agree with you that you took up the patient directly for a coronary intervention because the patient was in cardiogenic shock,
Yes.
right? If he was not in cardiogenic shock, and I was really wondering whether this is a stuck wall or whether it's a combination of the two, then even giving thrombolytic therapy would have helped this patient
Yes,
because there
ma'am.
was large thrombus burden. Secondly, while doing angioplasty also, if you
Exactly.
give intracoronary tenecteplase, your life is much more easier.
Yes,
So you
ma'am.
give tenecteplase on table, wait for 10-15 minutes, you see tremendous clearance
Yes,
of the
ma'am.
thrombus
Agreed,
burden.
agreed. But since we had already, we
Yeah.
were already there, so we thought let's try to open
Right.
it and.
Your,
see.
no, your plasty also becomes much more easier, the thrombus doesn't move so much.
Thrombus was more.
More.
Thrombus was
Load
more,
was
ma'am.
more.
We were lucky
Yeah.
to, take it out.
Yeah.
and-
Why radial route was?
Ma'am, that is our default route. We have been doing radial now for last 10, 12 years.
No, because stuck valve and all, radial to engage, you may find a difficulty in a prosthetic valve, like if you want to rotate the catheter.
Yes, yes, ma'am. We did it.
Careful.
We did
Yeah,
it over
is-
the wire,
yeah.
not allowing the
Yeah,
wire to
because
touch the
if
valve.
you-
Yes, ma'am.
We should not disturb the.
But I
radial.
think we are more comfortable doing radial since.
No, that is comfort
Absolutely.
is okay, but the prosthetic one, you have to, because now this is really a good case because now the number of TAVI interventions has increased.
Yes.
So we are going to see such kind of cases.
Definitely,
But
ma'am.
there's another last question is circumflex you had opened up, but if the patient, because there was a residual waste also, so why you had lived only with the POBA?
Yeah.
Ma'am,
Because
because
if
this
such
was a
patient
high.
will come again for recurrence, then again to re-intervene, it is going to be a difficult
Yes, ma'am.
task.
In this case, we didn't put in a stent, number one, because of high thrombus burden, and second, we had checked his angiogram. There was not much progression of disease for last 10 years. It was same as
No, but
done.
during inflation, there was a waste. There was a significant this thing. Only thrombus burden, that won't be a that much load. So what I feel is we can't leave such patients in a only
Yeah.
on POBA.
So even if you wish to leave them on POBA, I would maybe recheck them on the 5th day or 7th day
Yes, yes.
before I send them home.
Yeah.
I would maybe even image them in current
Because
times.
circumflex is the lifeline for such
Yes,
patients.
because
If it re-occlude
he had
that,
MR also, which
You will
settled
not
down
give
after the
another chance.
artery was opening, after he opened.
Very nice case.
Thank you so much, ma'am. Thank you.
Thank you. The next presentation is going to be Dr. Abhishek Samdeshi. His presentation is a dynamic enigma rate-dependent left bundle branch block. Please.